Hello friends, I am Dr. Sourabh Patwardhan from Nandadeep Eye Hospital PG Teaching Institute and FECO SICS Training Center, Sangli, Maharashtra, India. In our center, we have a lot of teaching activities which includes hands-on training as well. In this video, I'll be showing a case of fluid misdirection and how it can be rescued. So just a glimpse about this previous video which I had posted about fluid misdirection which may happen intraoperatively because of high bottle height or IOP, zonular weakness. It happens commonly in small or big eyes. It happens because the fluid passes through zonular defect or weakness and it starts getting collected in the potential space which is called Berger space, and as it collects, first step is that the posterior capsule becomes more redundant, and you will find that there will be undulating posterior capsule and there might be particulate matter in this space. It starts coming anteriorly. At this point you can reduce the IOP or bottle height, reduce the vacuum and flow rate, and use viscoelastic agent to form the AC again and perform careful phaco. But if you don't detect it at this point and you continue with high bottle height, the fluid accumulates and sometimes it becomes so tense that it results in acute intraoperative rock hard eye. So in between the stage there is still, you have some time to make sure that it doesn't go to the rock hard eye stage. So you can remove this fluid by either aspiration or tap using a 24 gauge needle or a MVR. Generally you don't need to actually aspirate. Even if you just make the opening, the fluid will gush out. The option 2 is to use a vitrectomy probe through pars plana, and you can cut the vitreous as well as antihyaloid. This is more useful when the pressure is high. And option 3 is to just wait, give IV mannitol, try to form the chamber with OVD, give Dimox. You can defer the surgery, just close the incision, defer the surgery. Once fluid settles down, you can go ahead with the surgery either on the same day or next day. Now here is a case which I want to demonstrate. One of our fellows is doing the surgery. It's a routine cataract, nothing different, but as the surgeon is getting ready for the last piece, you can see the pupil has come down a bit, and though we cannot watch this on this 2D video, the surgeon felt that the posterior capsule is coming anteriorly, so we reduced the vacuum to very minimal, 100 to 150 vacuum here, and at this vacuum surgeon completed the last piece emulsification. And at this point also you can just wait, you can put OVD and continue with the phaco, but here the PC was at this vacuum was relatively stable and could complete the phaco emulsification. So important thing at this point is to detect that the posterior capsule is bulging and make the necessary changes in the parameters. Now as the surgeon withdrew the phaco probe, you can see that there was little tensed posterior capsule, though intraocular pressure was still not high. So this was just initial stage of fluid misdirection where the fluid has gone into Berger space, it is bulging forward, and as you can see, the surgeon is trying to form the anterior chamber, make it deep for the IOL insertion, but not able to do that because the PC was bulging forward. Now surgeon had doubt whether it is PC still there or it's a vitreous which is bulging forward, so went with a blunt Sinski, and you can watch that as the surgeon touches the PC, you can see the reflex around it which indicates that the posterior capsule is intact. Many people fear to do this, but with a blunt instrument it is absolutely safe to check for the posterior capsule. Now again the surgery was handed over to a senior surgeon. Surgeon tried again to form the anterior chamber, where as you can see, as the OVD is pushed more, the iris starts prolapsing because PC is bulging forward. So decided to do pars plana tap with a 23 gauge MVR here, and as the MVR goes in and comes out, you can see that the fluid which has collected in the Berger space just comes out. No need to do any aspiration here. The direction of the MVR was towards the center of the globe. That is important to avoid any damage to the posterior capsule. And generally the Burgess space is bulging a lot, so usually it will rupture and it will clear the fluid through this pars plana. If you required, you can suture this with 7O vicryl, but mostly there will not be any vitreous incarceration in such a small incision. And this is done at around 3.5 millimeter from the limbus. And once you do this, you will find that now anterior chamber can be deepened easily with OVD, because now there is no fluid in the Burgess space. So now the IL goes in. At this point we could have applied maybe iris hooks to see further, as the pupil was not dilating well, but here the senior surgeon is operating now, so making sure that the IL goes into the bag. Now because of the fluid misdirection, the previous surgeon had not attempted any cortex removal, so the senior surgeon decided to remove the cortex, now retracting the pupil all around, and that was completed without any problem now. So in this way we could manage the situation and could complete the IL insertion in the same sitting. Thank you for watching.